I'm Dan Collins with Mercy Medical Center in Baltimore, Maryland, and you're watching Medoscopy. Thanks for joining us for today's procedure. Our guests are gynecologists Dr. Ann Peters and Dr. Tara Chadwick of the Gynecology Center at Mercy. Thanks for being on our show today.
Thanks for having us.
Always like to start off with the same question. Where are you all from?
Go ahead, Ann.
You go ahead.
I'm from Baltimore, Maryland, actually. So was born and raised here, left for college and came back and never left.
And where'd you go to college?
I went to Princeton, New Jersey.
Did you like New Jersey?
I did, actually. It gets a bad rap as a state, but it's beautiful.
It seems like New Jersey's kind of cut into two pieces. There's sort of like the chemical factory in New Jersey, and then there's the people like Alan Alda live in New Jersey. They have the rich people area.
Yeah, Princeton's a nice little enclave. It's definitely the Garden State there, but there are a couple exits up where you get the chemical factory appeal, definitely. Yeah.
And where in Baltimore?
I grew up in like around the Homeland area, so not
sure.
too far from here.
Yep, absolutely, know it well. And you, doctor?
I'm originally from Germany, so...
Deutschland.
All the way across. Good. Can't complain. So I grew up there, and then usually in 11th grade, a lot of people do an exchange year, either go to England or the US to kind of improve their English. And I came here for boarding school for 2 years, and then I just loved it and I stayed. So my whole family is still in Germany, and I'm just over here and, ventured into all things Baltimore and other places.
Where in Germany?
Cologne, Düsseldorf, Northwest area. So that's kind of born and raised. So I'm kind of stayed within that area, to be honest. Yeah.
I used to have a pen pal. She was just on the border between France and Germany.
Yeah.
And so I was in Paris. I was going to try to go visit, but just didn't have enough time.
Yeah.
So,
no, I mean, travel in Europe is a little bit easier sometimes, in terms of hopping across borders. And with the EU, it's not too many passport laws to get to other places. So that's a little bit nice in terms of getting around. But, you got to have the time.
So do you like Baltimore now?
Yeah, I mean, so I was in Connecticut initially for the first 2 years of high school, and then I actually went to Hopkins, to Johns Hopkins here. So I was here for my undergrad and my grad school before venturing down to Virginia. I was at University of Virginia at Charlottesville, and then did some other training for obviously the OBGYN residency and then my fellowship over in Pittsburgh before venturing back here because my husband at the time was here then.
So you got a lot of East Coast travel there.
A lot of East Coast travel, correct, yes. Up and down,
So why the interest in medicine? Was this something you both felt like, I always knew I was going to become a doctor, or it's like, no, I was going to write the great American novel, or I was going to be a chiropractor, or I don't know what I was going to be, but I didn't think I'd be a doctor. How did it all wind up for you?
I think it was something I always sort of saw myself doing. I think, as a young kid, I was always into like science and things like that, and really liked the idea of helping people. So it was something that was always on my radar. I took kind of more of a sidewinder way to get here, but it was always something I was interested in. But there were definitely times when I thought about doing other things. I was a politics major in college. So for me, I had an interest in public health and then briefly thought about law school. But medical school seemed like the lesser of two evils at that point.
So how did you wind up picking the lesser of two evils?
I'm not sure there's too much of a story, to be honest, in the sense of my father is a physician. So I remember from a younger point in my life, going to the hospital with him, not infrequently and observing surgeries. And I was like, okay, this seems good, let's venture into that. And then really never pursued any other kind of career pathway, I would say. Although I would say most of us in medicine can probably do some other things, but we're generally, of course, very driven people and want to change the world kind of people. So I think those talents can obviously be applied across the board, but I certainly can't complain as to how life has turned out.
Well, that's not unusual. Most of the folks I've interviewed have either sort of approached medicine from kind of sideways, like you mentioned, an interest in public health. I had a lot of doctors who were interested in engineering at one point, so sort of going from fixing machines to fixing people, or they had a family connection.
Yeah,
seemed to be the way to go.
Or medical engineering. Obviously, a lot of people that look into device design and getting their hands into that from a medical aspect.
So, Dr. Chadwick, I see you had an interest in infectious diseases. You received the Infectious Disease Society of America Medical Scholars Research Program grant at one time.
Yeah, so I actually, in between finishing college and medical school, I got a master's in public health, and my concentration was infectious disease epidemiology, which at the time, there was all this focus on chronic diseases, and then we had really kind of done a good job as a society of eliminating infectious diseases. I actually did my capstone project there on emerging zoonotic infections, so different infections converting from an animal to a human model, basically, which obviously became quite relevant with the pandemic. So I think that sort of disproved that we had gotten all of the infectious diseases under control and that pandemics are surely possible. So that's sort of what got me interested there. And then when I came to medical school, when I was deciding what I wanted to do, I thought really seriously about infectious diseases, and I applied for and was awarded the grant, which was great. So I got to do a research summer in between my first and second year of medical school in one of the infectious disease labs at Maryland, and which was amazing. They are the birthplace where they discovered the HIV virus, so it was a really exciting place to be. Their Center for Virology was awesome. So I learned a lot. I ended up taking a little bit of a different route once I started doing my clinical rotations, but that's sort of where that all came from.
So that was really kind of more research focused, and of course now you're more patient focused. Is that really the difference for you?
Yeah, I think when I was interested in infectious diseases, it was more the epidemiology aspect, how diseases spread, what makes a certain virus more contagious than another, and why do some viruses become what ends up as a global pandemic, and why are some just isolated. So I found that pretty fascinating. And then once you got into clinical medicine, you really just kind of get into what interests you more. I really liked being in the operating room, and as an ID physician, that's not really your scope of practice. So I just kind of found my niche a little bit more in OBGYN and then specifically GYN surgery. So I was able to pivot a little bit there, but it's definitely come in handy and it's something that I'm still interested in. So.
Now, Dr. Peters, you did some work in the field of molecular and cellular biology. Did you have an interest in genetics or becoming a research scientist at some point?
Yeah, interestingly, you say that. I actually started initially in the MD, PhD track of things. When I graduated from Hopkins, I actually tagged on another one-year master's in science before going on to medical school, and worked not necessarily with genetics, but worked with what's called induced pluripotent stem cells, which is essentially where you take a cell from anywhere in the body, a mature cell, not a stem cell, basically, that can lead to other cells in the body. And you almost kind of reprogram backwards into being a kind of embryonic stem cell where you can then actually guide that cell down different other pathways, again, to turn into other cells. So almost kind of tissue engineering or regeneration as a result of it. From an OBGYN standpoint, there was also thoughts on whether you could maybe recreate your own eggs, make new eggs, because women are born with the finite amount of eggs that they're born with, and once those run on, they run out, and that obviously is a problem from a fertility perspective. So the thought on that technology is whether you could actually create some new eggs yourself, basically, with your own cells. So I completed some of my research, my master's for that, and then thought about potentially doing a PhD at a time as well. Kind of initiated medical school, and then ultimately decided after going through the first couple of years of medical school training that I really wanted to dive more into the patient side of things rather than the research side of things. I mean, I think a lot of us try and integrate some of the research into our clinical practice as well. I think it depends a little bit of where you are and what your practice looks like at the time as to how much research versus patient care you can really provide to patients to do the best good in the world, the most.
Well, I think it's important to note that as physicians, you're always learning. And you are required to do so much continuing medical education every single year. I don't know how much the general public really understands that or knows that. They think, well, you went to medical school, you got your degree, and now you know everything. And so do you think that's important? Do you think patients understand that process and appreciate it?
I think that there's sort of a lack of understanding of the whole process of education for the medical community in general. I think that obviously you hope that your physicians are continuing to grow and learn. And I know both of us have probably had patients who bring in articles like, have you seen this? Do you know about this new thing? And most of us have already. And every once in a while, there's something new that somebody can bring us. But I think we're always at the point where we're always continuing to learn. And we talk amongst ourselves a lot. That I think is one of the benefits of being in a larger practice, the way that we operate, is that we bounce ideas off of each other. If somebody reads a new paper, we share it with the group and we can discuss. So I think you don't end up in medicine without a love of learning because there's so much of it that goes into there. But I think when you have a beginner's mindset where you're always thinking there's always something to learn, I always can get better, both technically in an OR capacity, but also just with your knowledge base, then that makes you a better physician to your patients. So I think, they don't always see what happens behind the curtain, but there's certainly a lot that goes into it that helps us be better providers.
Mm. Now, you're both experts in minimally invasive, like laparoscopic surgery, and I know it's fascinating. I remember Dr. Audlin had shown me a picture once, and it's like these two little red dots, and he said, one of these is a pimple, and the other one's the incision. And then he's like, can you tell the difference? And it's like, no, I couldn't. And it's like, that's the incision? So I was like, wow. So would you say that that's kind of become the gold standard now versus, and you've put away the, stem to stern, traditional open up patient that way? Is it really, it's not really like, oh, it's fascinating because it's minimally invasive. No, this is just how we do it now. Is that your mindset?
I think so. I mean, I think the majority of condition, to be honest, and this again is a bit of an advancement in technology that has kind of come with that evolution. I think the majority of our patients now expect, to be honest, to have minimally invasive surgery. And I would say that that is the predominant standard that we should all probably aim towards. I think it depends a little bit where in the country you are, because obviously some of it has to do with level of training in different physicians and what is available in your community. I mean, Dr. Chadwick and I both have completed extra 2 years of surgical training to be able to really offer this for all of our patients. And I think obviously recovery is easier, complications are easier, management of more complex gynecologic conditions like endometriosis are actually, in my opinion, easier to perform when we have a camera that can be really zoomed in on all what's happening in the pelvis rather than looking with the naked eyes at a large incision and not being able to see microscopic disease that you otherwise would not be able to detect with a large incision. That being said, there are places where, that advancement has not occurred yet, and patients still need to obviously have the care that they need for their conditions. And so I think while the trend is in that direction, and I think that's what we should strive towards, I think at the end of the day, you should do what surgery is the safest for your patients, but also keep it in mind that sometimes the safest or the better thing may be to refer your patient to another provider near you who has been able to acquire that skill, has that technology available in order to really give the best outcomes to the patients. And I think that's where sometimes we have to step back a little bit as physicians as well, similarly as you were saying with the learning, right? And reflect and see where one is at. But that should, I think, be the standard of care that I think most of us are aiming towards getting. But everything in medicine takes a bit of time and education, and ultimately we'll get there.
I agree. And I think that, with the laparoscopic advances, it's really helped us be able to treat things like endometriosis that we didn't necessarily treat very well when our only option was a big open incision. But there is still a time and a place for open surgery. I think both of us would agree that depending on, mostly we're going to do it for large fibroids, really large uteri that are up under somebody's ribs. It's really hard to put a camera in at that point. And so sometimes it's about, safety and decreased operative time, things like that. So it's not that we don't do open surgery. It's just that for most things that we treat, it's not the first option.
Great. Take a break and be back for the next half of Medoscopy.
The Gynecology Center at Mercy is something that I'm incredibly proud of. We are all fellowship trained with extensive and difficult backgrounds. We come from all over the country. We take care of fibroids and endometriosis, infertility, pelvic organ prolapse, and incontinence. Any advanced, complex gynecologic issue that you can think of, we have an expert that can manage it. We are multiple physicians in multiple offices. We basically encircle the entire Baltimore metropolitan area. We have patients come from all over the country for a specific person in a specific field, or come to the center because they realize that the quality of care here is unmatched anywhere else. We are able to match your office visit with your surgery so that you're not coming back and forth multiple times. We have helped many, many young women move on from their daily pain and live reproductively healthy lives, psychosexually healthy lives. Mercy's family. I mean, the whole entire hospital's family. A lot of the nurses come to our practice for care. Everywhere I go, I see a face that I know, someone smiling. You know, we want to make sure that we take care of everyone the same way. So this is the place to be.